Welcome back. We begin part two of the urinary system. And now we're going to start to look at the actual formation of urine and the kind of the mechanisms that go into the final product, in a sense, that is created by the kidneys themselves. And so we have some 200 liters or so of blood being secreted or being filtered throughout the day itself. And so many times over, the entire plasma volume itself is going through the kidneys and being filtered. And as we said before, that filtrate contains basically everything that's inside the plasma, except for whole cells, so red blood cells, white blood cells, and large proteins. For the most part, those are the things that are excluded from that filtrate that is there. And that being said, that means that we're going to have to take back the majority of the substances that we need to keep. And we're also going to have to ensure that we get rid of the metabolic wastes, all those nitrogenous wastes that the kidneys are designed to eliminate from the body itself. And so when we looked at it before, we said that the afferent arterioles bring in blood into the glomerulus, that we filter it out of the capillaries that are there, and our filtrate then heads down through the tubule. So it's going to go into the proximal convoluted tubule, to the loop of Henle, and then into the ascending loop of the loop of Henle, and then finally into the distal convoluted tubules, and then eventually into the collecting ducts. And that urine is then going to leave on its way to the bladder to be stored until urination occurs. That's there. After we created that filtrate, we're going to have to reclaim all of the things that we want to keep, so all of the vital nutrients that are there, hormones, etc. And then we're also going to have to secrete the components that are waste products that we have to get rid of. So we need to make sure that we get rid of all of those waste products, as well as reclaim everything that we need to keep inside the body itself. The kidneys glomeruli are made of fenestrated capillaries that are there, and they're highly efficient at doing filtration. So we essentially do a form of filtration out in all of the other tissues as well, but the filtrate that we create here is allowed to essentially ensure that all of the plasma is filtered out, and we're going to ensure that all of the waste products are lost in the urine and all of our vital nutrients are brought back in. We ensure that filtration through having high blood pressure. So the blood pressure is higher coming into the capillary bed than it is elsewhere in the body itself, which leads to a much higher net filtration pressure. So we talked about net filtration pressure back in the cardiovascular system. And here that same process applies, except that we're doing it at a much higher net filtration pressure than what we had in the rest of the tissues beforehand. So our net filtration pressure is essentially looking at the same concept as what we had before. We had hydrostatic pressure, we have osmotic pressure, and the hydrostatic pressures are going to essentially push the water out, and the hydrostatic or the osmotic pressures are going to try and pull that pressure back in that's there. And the hydrostatic pressure inside the glomerulus is key here. This is what's very high inside the glomeruli themselves. The oncotic pressure or osmotic pressure that's there inside the glomerulus itself is relatively low, so it's not going to pull back very much fluid back in. And then the hydrostatic pressure inside the capsule, so inside that capsular space, is relatively low as well. So the both of those combined are going to lead to a fairly high net filtration pressure, because there's not a whole lot trying to pull that or work against it inside the glomerulus itself there. So what we're concerned with when it comes to the kidneys is the glomerular filtration rate. And so when we're looking at kidney function, the GFR is one of the ideas that we look at as far as understanding how well the kidneys are actually functioning. So essentially, how much are the kidneys filtering over a given amount of time? So typically we look at things over the minute. So how much filtrate do we get? How much filtering are we having in that 1 minute? that is there. And that's going to then dictate essentially how well the kidneys themselves are functioning. The problem is that we can't really uh, specifically or directly measure GFR because we can't go into all of the little glomeruli and see how much fluid is actually coming out of there for those. And so this is a difficult concept to kind of think about, is that the GFR itself is not really something that we can look at specifically, and so we have to make an estimate of that. And so we're going to do that by looking at other lab values to get us an idea of where that actual filtration is occurring. We're going to look at things like inputs and outputs as far as how much water is coming into the person, how much water is going out of the person as well. And those combined are going to give us a good idea for how well things are functioning in the kidneys. So high hydrostatic pressure coming into the afferent arterial, relatively low pressures on the osmotic or oncotic pressure, and then relatively low pressure on that of the hydrostatic pressure inside the capsule itself. And so we're left with an outward pressure of relatively high, 10 millimeters of mercury or so, and that pressure is enough to drag basically everything with it to ensure that we have all substances coming out of the kidneys, and we're able to filter all the substances that we need to. There's a fine edge, in a sense, to glomerular filtration, though. If GFR is too high, then we're going to essentially push fluids through too quickly, and we're not going to be able to absorb substances that are there. So the needed substance cannot be reabsorbed quick enough and are lost in the urinary. And so essentially think about the entire loop. We start out at our capsule, we come down out through our proximal convoluted tubule, down the loop of Henle, and then back by the distal convoluted tubule, and then out through the collecting duct. If that flow, in a sense, is too great of the afferent and efferent arterial, then we're not going to be able to, because it's following the same pathway, we're not going to be able to reabsorb enough. If the GFR is too low, then essentially we're going to absorb everything. We're going to bring back in everything, including the waste that should be gotten rid of at that point. So we want to make sure that we have essentially a good balance between the GFR being high enough to do proper filtration and the GFR being not too low either, so that we're essentially making the blood toxic all the time. That's there. And so in order to regulate this, we have a few different processes that can help us out. And so we have an intrinsic system, we have the nervous system, and then we have hormonal control. And all three of those work to maintain the normal GFR within the kidneys themselves, kind of regardless of what's going on elsewhere in the body as well. So under normal conditions, kind of just sitting there doing not really anything, the kidneys themselves can basically control these processes all by themselves. And so autoregulation or intrinsic controls themselves have two different ways that this can occur. We can use myogenic controls by contracting smooth muscles in the renal blood vessels to alter blood flow. And so we can change the pressure as it's coming in and out of the kidneys. We talked about that before. And that allows us to maintain the pressure that is needed for a normal GFR. The other aspect of that is that we can look at the juxtaglomerular apparatus, and as flow is changing within the system, the juxtaglomerular apparatus is then going to make changes at the same time to allow for normal reabsorption and secretion to occur as well. Extrinsically, we have the blood vessels of the kidneys as well coming in and being controlled by the sympathetic nervous system. So sympathetic nervous system controls our smooth muscle in the capillary, or in the smooth muscles of the arterioles, And this is what's going to essentially either increase or decrease the amount of sympathetic tone that's there. And that's then going to allow for blood vessels to either be wide open or to constrict down, depending upon the amount of blood flow, what we're doing at that particular time, what our cardiac output is, and so on. The other type of extrinsic control that we have is hormonal. And so when we're under stress, we have the release of norepinephrine and epinephrine. So coming from the adrenal glands that sit on top of our kidneys there, the suprarenal glands. Those adrenal glands allow us to release norepinephrine and epinephrine. And the epinephrine is then going to cause vasoconstriction. And so we constrict those down. Filtration is essentially inhibited because if you think about it, if we're under a sympathetic state, we don't really need to be making urine if, in a sense, it's the last time we're going to be making urine. So if we're in that fight or flight state, urine is possibly the last thing that we really want to think about at that time. That's there. It's also going to stimulate the last mechanism itself, which is the release of renin. And so renin itself is released through a couple of different mechanisms themselves. And so we talked about its release in the beginning there. And as renin gets released, we have the juxtaglomerular apparatus kind of weighing in with this as well. And so as we have multiple processes that can lead to its release, essentially the common goal here, or the common factor, is a decrease in blood pressure. And so as we have a decrease in blood pressure, renin is going to become released. That's going to be sensed by the macula densa cells. It's going to be sensed by the juxtaglomerular cells. And we're going to get the release of that renin. The same thing can occur with our sympathetic nervous system, stimulating those cells to release as well. And so the renin-angiotensin system is kind of a cascade in a sense. And so we have renin being released. And so the juxtaglomerular cells themselves are releasing that renin. Renin then serves as a catalyst to convert angiotensinogen to angiotensin 1. Angiotensin 1 is then converted into angiotensin 2 as well. And then angiotensin 2 is our kind of our final product, so to speak. This is going to lead to vasoconstriction in the blood vessels. This is going to stimulate the adrenal glands to release more aldosterone. And so aldosterone is then going to cause the reabsorption of sodium. And all of this is going to lead to a rise in blood pressure. And so our blood pressure is going to go up, the hydrostatic pressure goes up, and our filtration continues on from there. So renin gets released by the kidneys, angiotensinogen was made by the liver, and then that angiotensin 1 then goes off for the most part up to the lungs. And in the lungs, we then have angiotensinogen converting enzyme, or angiotensin converting enzyme, sorry. And that ACE is then going to convert our angiotensin 1 to angiotensin 2. And so this is why you hear sometimes of things like ACE inhibitors. And so a cardiac patient may be on an ACE inhibitor, and that's going to decrease the amount of angiotensin 2 that is being formed, and thereby decrease blood pressure overall. So after we go through the process of filtration, we've got to get things back. We don't want to lose hormones. We don't want to lose glucose. We don't want to lose minerals and vitamins and so on that are all water soluble. So things are going to get reabsorbed back in through the tubules themselves. That way we can hold on to them and use them later on someplace else as well. So organic nutrients, things that are water soluble, are reabsorbed that are there. And so water, sodium, potassium, chloride ions, hydrogen ions, and so on are all going to potentially get reabsorbed. And some of the processes are going to be primary active transport, so they're going to require ATP. Some of the processes are going to be secondary active transport at times as well. So we can use other substances to bring them back in. And This again is all occurring along the tubules themselves. And so sodium is one of the more important substances that we are going to control its reabsorption of. And so this is going to be, in terms of that reabsorption, allow for us to either, if we lose the sodium, we're going to lose water with it and our volume is going to go down. Or if we retain that sodium, then we're going to retain water with it and our volume is going to go up, thereby raising blood pressure as well. That's there. And so sodium themselves get reabsorbed through the cells. And so they're at the luminal membrane of the tubules themselves. And then it's actively transported out of the tubules via a sodium-potassium pump. So this is going to be a partially, essentially, passive process, and then partially an active process as well for the sodium. From there, it's now into the peritubular capillaries. The peritubular capillaries have a relatively low hydrostatic pressure that's coming in there because we basically just filtered everything back out, and a high osmotic pressure for the blood itself. It's drawing water into it. So now sodium reabsorption is now going to provide for, because we have a high concentration of it there, this is going to provide for the reabsorption of other substances as well. So it's going to help to drag in other solutes that we want to bring across the membrane at the same time. For the most part, molecules are going to move through the cells themselves. So solutes are going to move through the cells through primary active transport. Some water-soluble substances can make their way through the cells through passive means as well. That is there. And they're going to move from the lumen over here eventually into the capillaries. And so that's why we have all those peritubular capillaries running with our tubules. So far, we're just in the proximal convoluted tubule here, and we're starting to reabsorb lots and lots of water as we're about to go down into the loop of Henle. But many in that proximal convoluted tubule, the majority of all of our solutes are going to get reabsorbed here in the first segment. The ability to reabsorb a substance, especially if it can't go through passively through either protein channels or through intercellular clefts that are there, the majority of them are going to require a protein carrier. And so the carrier that is there, essentially this protein that's going to allow for that movement, has a limited number. And so if we don't reabsorb a substance, it's either because we don't have enough, so the numbers of the carriers is too low, or we don't have a protein channel there at all. And so we don't have the ability to bring anything through there. So if we end up having too much of a particular substance, then that substance is going to be lost in the urine. It's not going to be able to be reabsorbed because there's essentially just too much of it. And so this is why when somebody has, say, diabetes and their blood sugar levels are too high, it spills out into their urine, not just because in a sense they have too much sugar, but because the kidneys don't have enough of the receptors to be able to reabsorb it all. If the kidneys had more receptors, more of those carrier proteins, they would be able to absorb or reabsorb even more of that glucose. And so it comes down to basically the numbers that are there. Do we have the numbers and do we have the energy there in terms of either ATP or some other substance like sodium to be able to drag it across the membrane with it? So if it's not something that we can absorb because we don't have it or because we oversaturate it, then it's going to spill out into the urine itself. And so think of things like blood sugar levels being too high in a diabetic, or if you were to eat something like asparagus, it spills out into the urine in terms of the odor that's there. And that's because we don't reabsorb the chemicals from that particular substance. Different portions of the tubules have abilities to absorb different substances. And so when it comes to the proximal convoluted tubule, the proximal convoluted tubule is going to reabsorb many of our nutrients that are there. A lot of our ions and cations, so all of our ability to reabsorb the charged molecules that we have there. Lots of water. And if any proteins, especially small ones, had slipped through, we can reabsorb those there as well. As we go through the loop of Henle, the descending loop's primary job is going to be the reabsorption of water. The ascending loop of the loop of Henle is going to be charged with essentially reabsorbing ions. And so we're going to take in all of the ions back in. It's going to become impermeable to water. And so the water is not going to come back in. So we've gone to a higher concentration. Now we're making it a lower concentration from there. The distal convoluted tubule is then going to once again be able to reabsorb water and then ions once again. And so this is where a lot of our water balance comes into play. And then the other side of that is pH balance. Acid-base reabsorption here in the distal convoluted tubule as well. And then lastly, as we enter into the collecting ducts, we're then able to make a final concentration of our urine by either reabsorbing water or not reabsorbing water and having dilute urine. So this is where we're going to kind of make that final product, this final push for the type of concentration of urine that we're going to have. One of the ways that we also maintain blood pressure is through ANP, or atrial natriuretic peptide. ANP is going to be there in kind of the opposite scenario of that of our renin, in that ANP is going to reduce blood pressure. So if we have a situation where a person's blood pressure is too high, we can release ANP, and that's going to allow for the loss of sodium. And with the loss of sodium, gets us a loss of water as well. And so this is going to lower the amount of sodium that we have, and kind of back to the scenario of where sodium and water kind of follow one another. The sodium that's getting lost kind of drags water with it at the same time. This occurs within the tubules themselves, towards the distal end of the tubule, so all of the medullary ducts that are there, and it basically blocks the reabsorption of sodium as it's coming in. And by that, it then decreases our blood pressure, and then we get a change in the GFR, reducing the GFR as well. So we have the ability to lose more of that water. The last component of the tubules is secretion. And so secretion is, in a sense, reabsorption in reverse, where now the substances that we must get rid of, and so our urea, uric acid, and creatinine, are going to be secreted out of the blood, so out of the peritubular capillaries and into the tubules. This then allows us to ensure that we get rid of it. And so we're eliminating our undesirable substances, all of our nitrogenous wastes that are there. We can do things like pump excess amounts of potassium into the urine as well. This allows us to pump either hydrogen ions or bicarbonate into the urine to control blood pH. This is just the way to ensure that all of the things that we need to get out of the blood, if they were missed in the initial filtration, are then gotten rid of from there. And so the next time we'll talk about the creation of our countercurrent mechanism, the ability to create that concentrated urine as we're going through the tubules themselves.